The session to our next moderator. Unfortunately, sorry for taking a lot of your session's time. Rick Santos, who is the president and CEO of IMA World Health, he will be moderating the next panel. He is a very passionate supporter of faith-based, particularly in Africa. IMA World Health works in several countries in Africa, particularly countries, even those in unstable situations, in crisis, supporting build health systems. So he has a lot of working experience with faith-based organizations, Christian health associations, in DRC, in Tanzania, in South Sudan. We collaborate with ACHAP for many years now. So it's really my pleasure to invite Rick to steer the next group of panelists. And we depend on your wisdom to see how you get us through to lunch in good time.
I'd like to ask the panelists to come forward. Jean Duff, Professor Marion Wari, Rosemary McGraw, and Dr. Amit Thakur. Hey, good afternoon, everyone. Welcome to our panel. It's called Making the Case for Effective Health Programs in UHC. My name is Rick Santos. As Dr. Miranda said, I am the CEO of IMA World Health, and I will be the moderator for the panel today. I was informed that Dr. Thakur is not here, so the good news is we have both more time for questions, a little bit more time for remarks, and hopefully be done on time. Well, we've had some really amazing conversations this morning. We've heard the presentations have been really wonderful. And I think one of the things that they've pointed out is that there's many challenges in achieving quality health programs, and from a faith perspective and UHC here in Africa. There are multiple challenges of getting donors in sync with national ministries of health and getting both in sync with the needs of facilities and communities, getting them in sync with faith-based communities, not to mention building multi-layered, multifunctional health systems across each country. So today we're going to look at some of these challenges. In particular, we're going to look at some of the challenges affecting health programming from actually three perspectives. Each of the panelists will have about 15 minutes to talk about their topic, and then we will, after that, we'll just open it up for questions. So the way I'd like to handle this is I'm just going to do the introductions of the person speaking, and then when they're done, I will introduce the next speaker. So this afternoon already, I'd like to introduce Jean Duff. Jean, and actually everyone, I have bios for everyone, and to be honest, if I read their entire bios, we would be here the entire time, and they'd have no time to speak. It's a very impressive group of people. But Jean has been, she is the president of the Partnership for Faith and Development, and this is an organization that supports faith groups in their work with governments, with international public and private sector, and it basically addresses the impact of local community health and development issues. Jean is the coordinator also of the Joint Learning Initiative on Faith and Local Communities, which is an international knowledge management platform for evidence for faith groups, activities, and contributions in community development and well-being. Jean also was the co-founder of the Center for Interfaith Action, or CIFA, as part of the Washington National Cathedral. And she is also the convener of a global initiative on faith, health, and development, and international collaboration to advocate for full inclusion of faith-based assets in development. So Jean has a wonderful background in this, and without taking any more of her time, Jean Duff, please give her a hand.
Thank you so much. Hello, everybody. What an honor to be invited here. I remember Sue Carey's remarks yesterday at the beginning of the wonderful seminar that she and Sue organized on Ebola and HIV, recognizing the extraordinary wisdom in the room. So now, having spoken to many of you, I'm even more humbled by the wisdom in the room. Dr. Komaroko, your presentation was absolutely fantastic and a wonderful precedent to my topic. I think we all know that the secret weapon to engagement for faith-based groups with governments is evidence. And I'm privileged today to speak on behalf of the Joint Learning Initiative on Faith in Local Communities on the topic of evidence drivers for effective partnerships between faith groups and public sector. A word perhaps about that slightly odd term, faith groups. We all argue all the time about our terminology. I use faith groups rather deliberately, and the illustrations are also intentionally chosen to include both the facilities and the faith-based hospitals and the faith-based healthcare delivery systems, but also the very important faith-based and religious networks that are such powerful influences for health-related attitude and behavior. Next slide, please. So I'll talk today, just in brief terms, I wanted to tell you about a very exciting invitation that I witnessed at the World Bank last week, and to set that in the context of brief remarks about the international development world, some of which has been already well addressed, and I will move fast through. I want to talk about the implications of that for faith groups and partnering, strengthening their partnerships with public sector. Tell you a little bit about the JLI, the Joint Learning Initiative on Faith in Local Communities, and to underscore that it is a way and a process, and by no means the definitive answer on evidence, but one that may interest you, and then to come to some recommendations. Last week I was very privileged to be in attendance, and I think what must be a historic meeting at the World Bank. Jim Kim spent almost 4 hours with international faith leaders, laying out the bank's twin goals of boosting shared prosperity and making the case for the doability of the second goal, which is ending extreme poverty by 2030. Now the bank defines extreme poverty in terms of the low number, living on $1.25 per day, and sets a numerical goal of bringing down the 1 billion or so people who are still living at that level, about 14.5% of the world's population, down to about 3% by 2030, and lays out a very strong case for the doability of that goal. One of the interesting things that I took from the meeting, and which we haven't actually heard yet in the excellent presentations today, is the whole notion that the investment in health is actually an investment in the economic growth of the country. And he quoted the important work of the Lancet Commission, that was led by Larry Summers, showing that 24% of economic growth results from better health outcomes. So the two are enormously intertwined, and we need to rethink our investment strategy as opposed to our funding strategy in that regard. So, in terms of the message to our community, President Kim was extremely active and passionate in calling first for a global movement around the twin goals. He called for solutions big enough to the challenge. He underscored his personal commitment to the preferential option for the poor, And as you may remember, he recently met with the Pope to discuss their common interest in that. And he seems very serious about that as a values paradigm, faith-based values paradigm. He calls for country-level full engagement with the faith community. And most interestingly, and why I'm underscoring it in my presentation today, insists, as he does, I think, in his leadership throughout the bank, and as his colleagues do as well, insists on a strong evidence-based framing for any partnership with the faith group. I can direct you on the JLI website, you'll see the address shortly, are the documents from the meeting, and I would direct you, those of you who are interested, to some more information about this meeting. This is a very important encouragement to our discussions here today, and to an interesting context for some of the presentations we've just heard. Echoing Dr. Custodia's focus on universal health coverage, I just would like to underscore again, if I may, the complementarity of the focus on prevention and community-based care alongside the necessity of improving facilities-based and treatment piece, and just to highlight it there for us to be reminded of. So in terms of the international development trends, as a framing for partnerships between public sector and faith groups, we see a move to community-based integrated healthcare. As we've heard, further gains will come from advances in prevention. And the faith community is ideally positioned to have a huge impact, and perhaps I would argue uniquely positioned in terms of its potential influence on key health-related behaviours. This will lead to, this emphasis on prevention will lead to a priority on health-related attitude and behaviour change. And again, the scaling up of faith-based influence and community-based networks is so important there. The trends suggest a scaled-up priority to evidence-based, locally adapted health solutions. The funding, as we know, is favouring local partnership. It's interesting to see some sharper teeth coming into some of the guidance from multilateral funders in relation to requiring governments, national governments, to have a more explicit engagement of faith groups in their discussions. Global Fund would be one to look at, where we are seeing now a new round of instructions that call for, I think, still inadequate, but definitely stronger engagement. And certainly, I think we would, as advocates in the faith community, we should continue to call on multilaterals to strengthen those requirements of national governments to get us to the table. Ebola certainly highlights the twin necessity of both faith-based health system strengthening, but also accessing, mobilizing, and equipping local faith communities. And perhaps we will really have an opportunity to take these twin lessons from the response to the crisis and many of the challenges in the response to the crisis. We've seen a priority on equity, and the Sustainable Development Goals are framing goals around equity, and a priority for reaching and serving those who are at the lowest income levels. And all in all, throughout these trends, we're seeing a renewed emphasis on effectiveness and efficiency, on evidence and value for money. So, what does this mean for faith groups, and what does it mean for ACHAP members? It means that we really need to push even further than the excellent work that is already going on, and I've learned so much from many of you in conversation. We need to push further to document both our facilities and our congregational assets and health outcomes. If we can go to governments with a clear and current picture of both the activity, the capacity, and the difference that we're making, we'll be in a much stronger position to get some MOUs that actually make sense. We need to look to collaborate across denominational and faith lines to deliver large-scale capacity. Governments don't want to work one by one. They don't want to work with singular faith entities. They need to be working with blocks and sectoral bodies, such as the Christian Health Associations, and even more broadly, multi-religious associations where that's possible and relevant. The opportunity, certainly, there's a very strong opportunity, I think a wonderful development for the ACHAPs, or the CHAPs, to push out the partnering between faith-based health systems and with their local faith leaders on social and community mobilization for prevention and emergency response. The boards of all of the CHAs and the leadership of the CHAs already involve the senior faith leaders in your communities, and many of you are already engaged in social mobilization at a very significant scale. So there's a real opportunity, I think, to push that out to respond to the international development trends. We need to demonstrate outcomes for the poorest of the poor. Very often the Christian health associations have an advantage in rural care and in care to those of lowest income. We need to actually show that in terms of our data and our evidence. We need to hold public and private partners accountable around even a range of the issues that were just discussed. And we need to make a collective evidence-based case to governments for faith-based delivery and community outreach. So to turn to the Joint Learning Initiative on faith and local communities, which has perhaps a share of some of this work. As Rick said, we are an international collaborative knowledge management platform, collecting and sharing evidence for faith groups' activity and contributions. The goal is to increase, the goal is through collaboration among policy, practice and academia to work towards the fullest possible engagement of faith groups in community health and development. And we believe obviously strongly that evidence is a fundamental tool in that engagement. We ask several questions. We ask, what do policymakers and practitioners want to know? What do they need to know? We ask, what are the evidence drivers for effective partnerships? We ask, what do we already know? There is much evidence already in place, but perhaps it's not communicated well. We ask, how can it be better communicated? We build on a methodology that was developed by Jeff Foster from Zimbabwe. Around, many of you will know his work on the Joint Learning Initiative for Children Living with AIDS. It's a joint learning hub-based methodology. The steering committee consists of policymakers, academics, and heads of faith-based organizations. And I'm delighted that Sally Smith and Rick Santos and Jill Olivier, all of whom serve on the steering committee, are here to represent the JLI as well. Currently our work proceeds through 5 international learning hubs, one in resilience, immunization, sexual and gender-based violence, HIV and maternal health, and capacity building. And I'll just lightly go through these. The Learning Hub on Resilience, which is co-chaired by Helen Stafsky and Alistair Agar at Alistair's at University, asks what is the impact of faith groups in promoting individual and community resilience in humanitarian situations. They've been, under the auspices of the Hub, very interesting research is being carried out looking at the role of local faith communities in strengthening resilience among Syrian refugees in camps in Jordan, for example, and documenting the unique and powerful role of local faith communities. These things we understand intuitively. We know that faith communities are first responders in disasters, but in fact there's very little evidence when it comes to a dialogue with UNHCR, for example, and they say, show me. They say we have difficulty engaging with the faith community. We have to be much more evidence-based in our response in those dialogues if we're to be taken seriously as partners. Sally Smith and Azar Karam co-chaired the Learning Hub on HIV and maternal health, which asks what are the activities and impact of faith groups on HIV and maternal health. And the scoping study, which is also on the website, and I would commend it to you, really supports the notion of the holistic delivery of care. That faith groups involved in HIV are also working in support of maternal health, and particularly the prevention of mother-child transmission of HIV. Jill Olivier has led the most magnificent, really the most beautiful piece of work, that again I commend to, the most current review of what faith groups are contributing to the acceptance and delivery of vaccine and immunization. The review and the annotated bibliography is available there. All of you are engaged as faith-based organizations in supporting vaccine, both acceptance and delivery, and it would be of great interest to further strengthen the evidence for the campaigns that you participate in, and to be able to produce that in your conversations with public sector organizations. There are 74 members and growing of the relatively newer Learning Hub on Sexual and Gender-Based Violence, which is co-chaired by Vino Sullivan and Liza Lutz, both based in South Africa. They ask what are the activities and contributions of local faith communities in the prevention of sexual and gender-based violence and the care of survivors, and are supporting an international movement to create safe spaces in the mosque and in the church for these issues, and to equip and mobilize faith leaders to do their part. The final hub that's in place now is a more cross-cutting hub that looks at capacity building for local faith communities. So many international organizations and nationally based entities such as yours are working hard to strengthen the capacity of faith groups to care for local communities and to collect and communicate data. This Learning Hub, interestingly, hosted a wonderful presentation by Channels of Hope. I see Darlene there. Recently, reaching out across faith lines to all of the members of the Hub, who would include Islamic Relief and Salvation Army and the Anglican Church and a whole variety of mainstream groups. World Vision reaching out with its Ebola training capabilities, which some of us were privileged to hear about yesterday, for new partnerships and bringing through the Learning Hub, bringing the capacity forward in that area. So here's the website address, very simple, jliflc.com. We'd be delighted if you would like to visit the site. Looking ahead briefly, there are 2 new hubs coming online, one in child health and survival, and one in peace and conflict. And perhaps you will help us imagine another one or 2. We're very much a learning network ourselves. We are not an institution. We are, at best, a very imperfect process, but a joint learning process. And we would welcome discussion from you about areas of your own interest that could coalesce into a hub. We're helping to organize an important conference in July, which will complement the World Bank invitation that I just described to you at the beginning of my remarks. This will be a conference to be hosted at the World Bank in Washington on effective partnerships between public sector and faith groups towards ending extreme poverty. Co-hosts for the conference will be USAID, DFID, the German development entity, and other partners as well. What an extraordinary opportunity for us to bring forward, and I really rely on you in the room, for us to bring forward the very best evidence to the policymakers who will be assembled at the World Bank for what we do and how we do it, and for how it is that we would like to more fully engage and more effectively engage with governments. So I will rely on you to assist us in thinking through what are the best stories and the best case and the best data to bring forward to this meeting. It's a really unique opportunity coming on the heels of the President's, Bank President's invitation. So in closing, our invitations to you, we invite you to join the Learning Hubs as you might be interested in the different themes, and to consider perhaps leading a new Learning Hub. To work with us to exchange information on what works, what doesn't, very importantly what doesn't. I think we're just as credible in the evidence game if we talk coherently and in a disciplined way about what doesn't work, and if we show that we're willing to learn from that. And finally, we hope to have African Christian Health Association platform participation in the July conference. Recommendations, in summary, if I may, to the group, echoing Jim Kim's word, solutions big enough for the challenge. The collective might and power in this room is certainly a solution big enough for the challenge. The question is, can we get this taken seriously? Can we get seen as the collective force that is represented in this room? And can we make a collective case? So three areas of recommendation in summary. Work hard to continue to improve the evidence base, share knowledge, look to forge new research partnerships with academia, with folks like ACHAP, represented there by Jill Olivier. Scaling up faith group collaboration, exploring innovative ways to collaborate across denominations and across faith lines to strengthen the collective voice. partnerships between facilities-based organizations and faith communities networks, and intentionally equipping and mobilizing local faith leaders and communities so that they can do good work at the grassroots. Finally, making the case to the public sector, authorizing collective representation. Again, the faith community governments have difficulty dealing one by one. Organizations like the Christian Health Associations are important collective voices. Do they need to be expanded to be fully inclusive of other religious groups? And would that be effective in some cases? Aligning with national plans very intentionally, which of course many of you now do. And focusing on evidence, how faith groups deliver outcomes, particularly for people living in extremely low incomes, but not exclusively. Great. Thank you so much.
Jean, thank you very much. It's a wonderful presentation, and we're going to move on to the next one. I know we have a little bit of a time press. So I would like to introduce the next panelist, Professor Marian Wari, who will discuss community health systems to bring effective health programs and services to every household. And I have to say I'm quite honored to be on the same stage with Professor Wari. She is really esteemed person in Kenya, and her body of work for her career is amazing. Just to go quickly over her bio, she has a degree of biology and chemistry and physics from William Penn College in Iowa. She did some postgraduate, she did a postgraduate diploma in education from the Makari Uganda University, where she taught secondary schools in Kenya. And then at another point in her life, she decided to study medicine and has a degree from medicine from the University of Nairobi. Now added to that, she also has a degree in public health from Johns Hopkins University School of Public Health, and she has both a master's and a doctorate from Johns Hopkins. So it's really an amazing history and academic career. She has worked throughout her time here in Kenya in a variety of things. I don't want to go into everyone because it's a very long list. But just to say that in her career in health services expansion and research in Kenya and in other countries, she has focused on community health approach, both within the public sector and in not-for-profit organizations. And just to say she's been honored many times, and most recently she was honored, designated Kenya's Community Health Strategy Goodwill Ambassador, a title that she holds today. So please give a warm applause.
Thank you very much, Rich. As you have been told, I'm going to speak on the role of community health services in creating effective health programs towards universal health coverage. Now, a lot of us know about community health programs, community-based health activities, and the challenge that usually comes to us is the challenge of knowing what we mean. Many times people don't take community health seriously, and they usually say, oh, those people sitting under the tree talking about some things about washing hands and the trees. And so if we are an effective community health service, what should we expect? What should people expect? And I listed some things down that I think people should expect or we should expect if we are running effective community health services. One of them is that we should expect there should be good understanding of health promotion. If we are working in community health services, we should expect that our audience, the people that we work with, the community members, households, have a good understanding of health promotion. how to promote health in their lives. There should be good understanding of disease prevention, the diseases that are in their lives, how could they be prevented, which ones could be prevented, and they report on communicable and non-communicable diseases. We should expect them to understand what good health-seeking behavior is. Now, what constitutes good health-seeking behavior? Our people should understand that in our communities, if they are going through successful, effective community health services. They should also understand the proper use of facilities. How do they use health facilities? Our people should also understand what it means to have compliance with treatment regimes. If a health professional tells them a particular treatment regime, what is the importance of compliance? This should be part of the information of the people who are working in community health systems. What are the referral systems, if there are any, or if there are none? If there are any, what would they be if they were present? And then there should be an understanding of the proper handling of social determinants of health. Which factors in our societies, in our communities, would help to promote health in our lives? What is the role of education, for instance, in promoting health? What is the role of food production in health? What is the role of good housing, water, sanitation? This should be an understanding that our people have if they are going through effective community health programs. And there should be a financing mechanism that supports the community health services, which is one of the biggest challenges that community health services have. So in such a community health service which is effective, there will be a lot of contribution towards universal health coverage. And the point I'm making is that if we establish effective community health services, we shall be establishing the foundation for national health systems. And that such a national health system would, in fact, provide universal health coverage. But in order to establish these effective community health services, I think that we need to be aware that there needs to be a structured approach to establishing community health services. That we think about it carefully and be structured so that it can actually become an effective community health service. So the goal, what should be the goal of community health services? The goal is to bring basic health services to every household. We had the director said this morning that we shouldn't be concerned only with basic health services, we should be concerned with comprehensive health services. But what we have found is that at the community level, if you begin with basic health services, you are doing well, on which they can then subsequently build, so that health is brought, the concepts of health, access to health, is brought close to the community, both physically and social-culturally. We have found in some of the research we have carried out that people living next to a health facility don't necessarily use the health facility. And why? Because of the social-cultural distance between the health facility and the health and the people. We have found that you can have a very good health facility in a country, but if people are very far from it geographically, they don't benefit from it. So the goal is to reduce the distance between the facility, the modern health services, evidence-based health services, and the people, both physically and social-culturally. We should have a clear vision, and that clear vision should include that we are talking about people living healthy and good quality lives in households, at the household level, in robust communities, so that people are living healthy lives, good quality lives in healthy communities. We should have a clear mission being that the mission should be that we are actually using the community health approach as a means to establishing holistic development. Because as it has been said, if you can improve health, you can improve the economic development of the situation. And if you are improving the health of the community, you can have holistic development, especially since you have to deal with determinants of health when you are dealing with these things at the community level. And one of the important findings that we have seen in our work in communities is that if it happens at the community, it happens in the nation. And if it doesn't happen at the community, it doesn't happen. So investing in communities is not wasting time, because if it happens in the community, it happens in the nation. And if it doesn't happen at the community, it doesn't happen. So what are some of the organizational considerations that we should have when we are considering establishing effective community health services? One of them is that there should be a clear understanding of what our community is. We have found that there can be very varied discussions, very varied concepts about what our community is. And it seems that in every nation which is practicing community-based health care, there should be an understanding of what our community is. In Kenya, we had long debates over this matter, one group, one project defining it differently, and another defining it differently. And eventually, when the Ministry of Health became involved in the community health services, we got to one definition. That is to say, we took the smallest administrative unit in the country, the sub-location, to be the community. This is because if you say the sub-location, everyone understands what it is, and they can then relate to it because everyone understands what a community is. We have found this to be a very great supportive element in the work of community health services. A community defined as a sub-location means that there will be several villages in the community. In other words, a community does not necessarily equal a village, because in many countries, a village can be very, very small, 20 households, and if you divide the country into 20 household units, which are the communities, the numbers become overwhelming and they become rather difficult to work with. So the sub-location is about 5,000 people who constitute about 1,000 households. Although this is very different in various parts of the country because of the density population being variable in various groups. Also, another factor in terms of organizing community health services, once you have understood what a community is, or you have agreed on what constitutes a community, then you need to have a community health committee. And this is not only a Kenyan experience, it is also an experience from other countries, Ghana, Rwanda, Ethiopia, that if you need to have a community health committee, which takes up the leadership in terms of leadership and governance oversight. Who decides, or when you have a meeting, who decides on the general things around which the community health activities are structured. Then you need to have a clear idea of community level health workers. Who constitutes the community level health workers? We have found that having a general information that is agreed upon in the country makes this very important. For instance, in Ethiopia, they have the health extension workers. In Ghana, they have the national tropical nurse. In Kenya, we have the community health extension worker or the community health assistant. so that there's an understanding in each country as to who leads the work at the community level. And when that is done, then there is clarity in terms of who is heading the work at the community level and what kind of work does it happen. What kind of work should this leader provide? Then at the same time, you have other people who are working with the community leader in terms of community health leader. And we have found that community health volunteers are very important. Community health volunteers used to be called community health workers, but in most cases, these are not people who are paid. Community health extension workers are members of the government because they are trained in formal training and they just become engaged at the community level. Community health volunteers are not formally trained, but they are trained in terms of being given information, and their main role is to keep contact, close contact with the households. So you'll find that in community health volunteers, they have been trained in preventive ideas of preventive medicine, health promoting medicine, health preventive ideas, and they are trained in communication skills, how to support the households. And in most cases, you find that the community health volunteer is representing or coming from a village, so that you have either 10 households or 10 households who the community health volunteer comes from. And the community health volunteer then is the one that is in complete contact with the community health, with the household. And then the community health as extension worker, or the community health community extension worker is in touch with the community through these people. In Ethiopia, they even call it the community health army, so that these community health volunteers become the main contact between the community and the people. So you need to have, you cannot have an effective community health service unless you have got a clear idea of who the community level health workers are going to be or are. In some countries, there is the community midwives. The community midwife is also a trained midwife who is engaged at the community level. And this is popular, especially in those countries where we still have high maternal mortality rates. So that the community volunteer midwife provides services at the community level. The community midwives can provide these services in terms of antenatal service care and making sure that the expectant mothers go to deliver in health facilities. And if the health facilities is very far, the community midwife helps the family to have a bad plan in terms of where will she deliver when the time comes and how will she get there. Does she need to go in advance, or does she need to go ahead of time? Does she need to go a week ahead of time, or how far in time should she go to the health facility where she will deliver? It has been shown in the literature that community maternal mortality is not very much reduced when the delivery takes place at the village level because of the complications of deliveries, which cannot be handled at the community level. So it is useful to have a maternity, a community midwife who can advise the expectant mother on antenatal issues and also on birth planning, so that they will know where to go to deliver their baby. If you're going to have community health level workers, then you need to have a curriculum. And the curriculum then is planned in a different way. For instance, the curriculum for community health volunteers can be more basic, can be quite basic. In the Kenyan setting, we have two groups of curriculum. We have the basic introductory modules of the curriculum, which among them is the introduction, the idea of health and development. What are the links between health and development? And out of these basic modules, we have 6 basic modules through which we train community health volunteers. Then the technical modules talk about integrated community health care, community-based health care. For instance, what are the community health, what kind of services can be provided at the community level? Maybe something like malaria tablets can be given at the community level, because people can buy malaria tablets off the counter in the market. So they can be trained how to provide this very well. How to do water and sanitation and personal hygiene, household hygiene, so that there should be a clear curriculum in terms of how to provide for the community health volunteer. So that although the training is flexible in terms of the actual delivery, it is in any case structured. It is structured in order to provide health facilities, health services that can be good quality. The community training for the choose for the community health extension worker is more formalized and usually takes a year, while the other one takes 2 months at a time and it takes 2 months at a time and it can take two weeks at a time, and then the community volunteer goes to work and then comes back later. The community health extension workers curriculum is more structured and more professionalized. So the important point we can make in this time that we have is to say there should be a structured curriculum that is clear to everybody and clear to the people. Then, in all this, for instance, among the community health extension workers curriculum, there will be topics on facilitating supervision and monitoring, evaluation, and reporting, because this is one of the duties that we carry out. The community health extension worker supports the work of the community health volunteer, and they supervise the community health volunteer. So this one helps them to understand how to do the supervision and how to do the monitoring. When we have done the basic understanding of what the community is, what the community health community is, what the community health workers are, during this training, we are also making it clear what kind of support the community level is going to be receiving. And this is the level that usually the formal government usually lets down the community level, because usually the help that is needed at the community level is not often forthcoming. But I'm happy to say that in a country like Ethiopia, the help is very structured from the formal government. Also in Ghana and Venezuela, the help is very structured from the formal government to the community. In Kenya, it is very good to see that the county governments are very keen on stepping up the training of the establishment of community health services, so that they can provide the kind of support that is required for the community health service to be vibrant and robust. And finally, there needs to have standards for community health service. For a long time in Kenya, we didn't have standards for community health service. But now, standards have been established. And these standards help to know what to look for. So if you have a general curriculum that is being rolled out in the country, but how do you know how well it's being rolled out? So the standards become very important in terms of the quality assurance and quality control. And this way, you can know exactly what kind of quality is being delivered, what kind of quality is being delivered, and how is it being delivered. This also allows the health worker, who is the overall supervisor, to have a good idea in terms of what is happening in various parts of the country. Is the health facility is the community health services being carried out as well in one area as well as in the other, or this one area not doing as well. It's the community health service improving or deteriorating all the time. So that when it is all the time improving, we can know how to make it work better. So standards are very helpful to develop because you can establish a framework for comparison all the time and for comparison between communities. And you can establish this as a basis for learning, communities learning from one another. If one is doing particularly well in one area, you can invite them to go to another community so that they can learn from that community. And they can help learn from one another in various areas. Another item which I can define about is the client satisfaction. Sometimes you can go to a community health service where it says a matter of giving orders. But fortunately, if it says a matter of giving orders, usually it doesn't work very well. And because we go back to the definition of health, and the definition of health being health is a state of physical, mental, and social well-being, and not necessarily the absence of disease or infirmity. So always at the back of the mind should be that, are the people enjoying this, what we are doing together? Are the people happy about it? Are the people involved in discussion? And that's why it is important to establish community dialogue sessions so that people can actually take part in the discussion, community action sessions, so that people can be informed in carrying out some of the tasks together as a joint activity. So if we can actually do this as a way of making the people enjoy themselves as they learn, it becomes a very strong point for improving the community health service. Because if it happens at the community, it will happen in the nation. And if it doesn't happen at the community, it will not happen in the nation. What I would like to commend this group is that faith-based groups which are in one area, but from different denominations, it seems to me that it would be a good idea as a way of, because most of the community health work was begun by faith-based groups. It would be a good idea for the groups which are in one geographical area, in Kenya, I can say in the county, or in the region in Ethiopia, or in the province, to come together and say who would be responsible for which community. Because our faith doesn't go geographically, but we can still provide services in terms of geographical growth. That this area can be provided health facility, community-based health services by the African Church, and that area by the Church of God, and this area by the Methodist Church, so that the communities are covered. And I think that if the community, if the faith-based groups take that kind of approach, we can really contribute to universal health coverage, because we can make sure that every community is covered, and we are covering everybody so that nobody is being left out. And I think that if we can do that in an organized way, then it will add our voices together when we can have negotiation with the government and with the external bodies like IFC or World Bank, so that they can support what the churches are doing. All the time I was growing up in the 1940s and 1950s, all the facilities that were there were from the church. They were none other. Just at the schools, they were from the church, working at the village level. So I think the church has this experience, and the church has a particular strength of working with the community health service level, as well as at the first referral level. So that as you work in the community, you develop the first referral level, what in Kenya we call the link facility, so that they become the referral center for the community, and they become the supervisor of the community. So I believe that in this area of universal health coverage, the church has a lot of potential and a lot of opportunities to actually contribute in a very substantial way to universal health coverage. Thank you very much.
speaker is Rosemary Nguru. She will be talking about domestic health financing from a global fund and Gavi perspective, and in view of both the recent Gavi replenishment and the global fund replenishment upcoming, and those investments, and those successful investments in the health system. She's going to talk about how governments now, for this to be sustainable, need to up their own game in terms of domestic financing. A little bit about Rosemary. She has over 10 years of international experience in areas of public health research, program, and advocacy. A civil society organizer who has extensively worked on building and strengthening civil society networks and platforms on HIV and AIDS, health advocacy, and campaigns in Africa. Rosemary coordinates the Global Fund Advocates Network, and she works for the World's AIDS Campaign and hosts the African Civil Society Platform on Health. She also, I just found out today, as with me, sits on the Gavi CSO Steering Committee. She holds a Master of Public Health from Ohio University and a Master's in Business Administration from Frostburg State University in Maryland.
Thank you. Good afternoon.
Good afternoon.
Good afternoon.
Good afternoon.
I think I need more energy. I have the honor of speaking just before lunch or just after lunch, so I know I definitely have your undivided attention. So I want to appreciate Professor Robo's presentation. The spirit of his presentation will continue to be reflected in my presentation. The main backdrop of my presentation is the Global Fund's FAID replenishment, as well as Gavi's replenishment that just ended in January, actually launched it in January. And within that context is to acknowledge that those of us from Africa, we are categorized as implementing countries. If you look at the Global Fund and the way the things are divided up there, we have the donor countries and we have the implementing countries. So then I guess we are primarily concerned with how we as implementing countries get the resources to implement the different interventions that we have. But rarely do we take time, maybe we do, maybe we don't, to think about then once we get the money from the Global Fund or from Gavi, how do those institutions then replenish those funding awaiting for the next allocations? So basically it's to look at how do they get replenished, and is there a role within that replenishment for domestic resource mobilization? So the presentation will be highlights from the Global Fund's domestic financing strategy in the context of resource mobilization. And just to clarify that when we talk about domestic resource mobilization in the context of the Global Fund, we are not talking about implementing countries or African countries or national governments putting money into the Global Fund. That would still be nice and I think appreciated, but within the Global Fund strategy for domestic financing, and it is the same strategy for Gavi for domestic financing, is really to call upon African governments or national governments of implementing countries to invest in their own countries in health. So this is all premised on the realization that donors cannot do it alone, and that we have heard increasingly now donors calling African governments or implementing countries for that matter to take up more ownership in the responses, to take up more ownership in financing or investing in the disease programs that we have. And that ultimately is geared towards sustainability and predictability of financing. Next slide, please. So what is the Global Fund doing at the moment? It's working with countries and partners to leverage on the Global Fund resources. This is to
encourage increased government commitments to disease programs and related health system strengthening. We do know that in accordance with the policy on counter-financing or counterpart financing at the Global Fund, applicant countries are required to demonstrate that government contribution to the National Disease Program reaches the counterpart financing threshold. And that is different for different countries, depending on whether you are low-income country or low-income country or upper low-income country. The other thing the Global Fund is doing is to improve data quality and accessibility for both domestic and international health funding. Basically working with the Global Fund country teams and the Treasury and the different groups involved in determining that to improve the data quality and accessibility of those, either by the ministries of health or other sectors in the country, as well as civil society. The other thing is to identify and address rigid budgeting practices, allocative inefficiencies that are obstacles to the reallocation of revenues towards health. One of the things that happened with the Global Fund when the Ebola crisis came up in Liberia was that the Global Fund was able to reallocate some of the financing that had been budgeted for certain interventions, and looking at the emergency at hand, there was ability and flexibility to reallocate those revenues. And so, why would the same not happen at the country level, that flexibility for certain times? The other thing that the Global Fund Secretariat is doing is to foster effective dialogue between local health and finance officials. We realize that the relationship between the Ministers of Finance and the Ministers of Health is not necessarily or always one that gets us to where we want in terms of more money for health. And so, working on that relationship. Last year, the Global Fund, together with the African Development Bank and the African Union Commission, convened a summit for the African Union Ministers of Health and African Union Ministers of Finance in Addis. And in that conference, they had prioritized the Global Fund's priority countries. There are about 8 countries in Africa, and none of the Ministers of Finance showed up at all. So we just had a conversation and a dialogue with Ministers of Health. So really not a dialogue, I guess they were speaking to themselves. And then also supporting countries in establishing an acceptable benchmark on a country-by-country basis and discussions on innovative domestic resource mobilization tools. Now, we know Africa has made commitments. For us, on the civil society side, when we engage in advocacy on domestic financing, calling the government to increase funding for health, we've always used the Abuja Declaration, 15% as a benchmark. But what the health economists are telling us is that we are probably maybe wasting our time if we benchmark with the 15% Abuja Declaration. So the more progressive and productive way to go is to take country by country scenario and to see how much can that country, what are the opportunities within that country, what are the different dynamics in that country. Some countries could perhaps even do 15%. So there's an ongoing discussion to help countries set their own benchmarks. Then there's a whole discussion around nurturing political leadership. So when the Global Fund engaged in the fourth replenishment campaign, they engaged African leaders as champions. So we had African heads of states, we had African first ladies who championed the Global Fund replenishment, and that is something that is still going on for the fifth replenishment. And then also, the Secretariat is working to revisit and raise awareness on economic arguments for health, including how it makes macroeconomic sense. So really looking at the different business cases and economic cases for why should we invest in health. And of course, supporting the universal health coverage discussion within the post-2015 agenda. So this chart basically is to tell us that everybody is on the table, looking at Global Fund funds advocacy model for increased domestic financing for health. So it's really talking to the decision makers, that's the heads of states, the ministers, and then there are different stakeholders from different sectors that are involved. There is a box for NGOs, and I want to believe that is where the faith-based organizations will fall. So I guess the question and the challenge for all of us is to say, are we at the table when these decisions are being made, when the discussions are being made? I know Dr. Mweda is at the KCM, so maybe that's just one voice, but it's also a question of how we engage in communication, feedback, and consultation, and how we can support his role, for example, in that position. Next. So some key challenges, 3 of them, they've already been mentioned by those who spoke before me on domestic financing, value for money. As the resource landscape is changing, focus is now more on health efficiency and effectiveness, which calls for both more money for health and more health for money. Domestic advocacy, a large part of any increase in public funding for health will need to come from governments. Therefore, they need to develop a convincing business and advocacy case for increased or sustainable public commitments to programs. So that really just speaks to us as organizing ourselves within the health sector to make a convincing business case or economic case for why more money for health. Sustainability in terms of domestic public spending should continue as economic growth continues. And basically we are saying that we are not saying that we need domestic financing to replace external funding 100%. There is a transition process, but governments need to start taking ownership at the moment. Now is a great time to do that. These have been mentioned. When we did our campaigns and advocacy previously, calling African governments to increase domestic financing in health, we kept pushing the governments to increase to 15%. But we really never had a conversation of, well, what are the different sources of the 15%? What are the different new innovative ways that governments can use to raise resources? So this had been mentioned, the ALFD, different 2% of public sector budgets in the mark for HIV, mobile phone levy, etc. Next slide. So areas to work on. So what does all this mean for us? What this means for us as people working in the faith-based sector, responding to health in different countries in Africa is that number one, if we are going to call our government or to succeed in seeing an increment in domestic investments in health, we are going to need to recognize and improve the role of civil society. Our role as civil society, our role as FBOs, our role as non-state actors in demanding. Because the demand side, we have to work on that and to use facts, to use evidence, to use economic cases to do that. So we need to recognize that. And one of the things that Gavin has done, it has an approach on engaging faith-based organization. And within that approach, there is an advocacy strategy that has 4 pillars that faith-based organizations can capitalize on. Gavin is looking more at outreach, partnerships, country engagement, and information. And so there's a space. There's a platform that we can take advantage on and engage more with Global Fund, engage more with Gavin. Then we need to address the core question. Is it possible to define the right mix of domestic and international investment in any country? This will vary from country by country, but in terms of taking ownership, in terms of working towards sustainability and predictability, we need to look and find what that right mix is. And finally, establish on a country-by-country basis an acceptable benchmark for countries to invest from their own resources. At the moment, we are working on a 2-year campaign with civil society in Kenya, in Tanzania, and in Senegal. And the biggest challenge is, what is our ask? How much of an increment should we ask the government to put into health? And Kenya is especially, the dynamics are really, can be challenging. in setting that benchmark because of the resolution. So you really don't know exactly what you want to ask for, because we tend to ask for a blanket benchmark for all the counties. So there's need to look at county by county, case by case, and then to look at the different functions. The national government has its own functions, the county government has its own functions. And that's just one example of the challenges that countries experience. I would like to acknowledge the Global Fund. So this presentation was mainly informed by the Global Fund strategy of domestic financing. I work for the Global Fund I am a member of the Global Fund advocacy network. It's called GFund, that works closely with the Global Fund Secretariat on Global Fund resource mobilization, which now includes domestic resource mobilization. I want to acknowledge Linda Mafu, who is the head of political and civil society advocacy of the Global Fund, for her technical inputs in the presentation. And I also want to acknowledge the Global Fund Advocacy Network that is supporting civil society to align to domestic financing advocacy in light of the faith replenishment. Therefore, in ending, as faith-based organization, there is an opportunity for us to join hands as civil society and to engage in a coordinated civil society response towards ensuring that there's increased investment at the country level through domestic resources. Thank you.
Thank you, Rosemary. In terms of timing, is there time for a few questions, or should we ask Sam? I think the other option would be, if we go to lunch, that if you want to speak to our panelists individually, one-on-one, and ask them questions, you can do that. So let's just say a round warm of thank you and applause for our panelists. Virginie, highlighting the real need for evidence and evidence-driven interventions, and the faith community needs to be better at that. For Professor Wari for talking about the need for really a community health approach and community health system, and then of course Rosemary for her talk about domestic health financing. Again, thank you very much. Is there announcements about lunch?